Hello and welcome. My name is Dr. Joshua Gordon. I'm the director of the National Institute of Mental Health, or NIMH. I'm joined by my colleague, Dr. Jane Pearson, chief of the Suicide Research Consortium and program chief for suicide prevention efforts in NIMH's Division of Services and Intervention Research. We're hosting today's Facebook Live event in recognition of Suicide Prevention Week. During this chat, we're going to discuss some of our most recent research findings in suicide prevention, and as well as discussing treatment approaches, warning signs, and really how anyone can intervene to help save a life. Our Facebook viewers will also have the opportunity to ask questions. So please, if you do have questions, type them into the comments section on our Facebook Live event page. We're going to try to get to as many as possible during the discussion. Before we get started, though, I do want to say to anyone out there who might be having difficulties, who might be thinking about harming themselves or trying to kill themselves, please call the Suicide Prevention Lifeline at 1-800-273-TALK. That's 1-800-273-8255, or visit their website, suicidepreventionlifeline.org, for help. Okay, well, before we get to questions, we're just going to talk a little bit to introduce you to the kinds of research findings we've been discovering here at NIMH. And to introduce us, I'll ask Jane to tell us about some of our chief goals in that area.
Great. Thanks, Josh. So NIMH has supported suicide prevention research for some time, but we've been accumulating evidence, so I think we're at some points in our science where we can really apply what we've learned. And it's coming at a good time. We have our partners at the National Action Alliance for Suicide Prevention who've set goals of reducing the suicide rate in the U.S. by 20% by the year 2025. So you might hear the 2025 goal advertised by them and having everybody work towards that same goal. And one way we've thought about this more recently is to understand where people have died. When people have died by suicide, what setting had they been in recently? And we've looked at this from a number of ways and different age groups. And one of the things we're finding is that a lot of people go to healthcare before they die. Some talk about suicide, some don't. And it's not that going to healthcare necessarily is a risk factor, but because people go there yearly, typically, that's an opportunity to find them.
So healthcare settings, whether it be primary care doctors or emergency rooms, these are opportunities to identify who might be at risk. And although many people are identified by their healthcare providers as being at risk, what we've found through the research is that if you ask everybody,
Right.
whether you're in the emergency room or your primary care doctor, if you ask everybody whether they've been thinking about harming themselves or killing themselves, you identify a lot more people who are at risk. And in fact, our research has shown further that once you can identify them, you can reduce that risk through some pretty straightforward interventions. So the idea of identifying opportunities, identifying individuals at risk, and intervening, that's a mainstay of our research.
Absolutely. And what we're trying to develop now are tools for providers to think about, okay, if somebody is screening positive, how do we talk more about this to understand sort of their level of risk? Like what kind of resources do they need? And also helping them think through a clinical workflow, because we know they're very busy already. So if we're asking them to add this to their list of questions, we want to make sure people get the appropriate care that they need.
So we focused on healthcare providers, emergency rooms, and primary care doctors. We've also got research showing that using electronic medical records, one can also identify people at risk so that we can remind doctors to ask the right questions, as well as looking for effective means of intervening, particularly in children and adolescents who we know the rates of suicide have been increasing dramatically in that younger age group. In fact, we've developed here in our own research centers at the NIMH a screening toolkit specifically designed for healthcare providers to be able to ask children and adolescents about suicide. It's called the ASQ. It's available through our website. That's nimh.nih.gov. And it's an effective tool to identify children and adolescents at risk. So with that introduction, we're going to go ahead and take some questions from the Facebook Live viewing audience. So please go ahead and type the questions into the comments and they'll pop up here. We'll try to get to them as many as possible. One of the questions that really comes up quite often is, and I see it's come up already here, is what are the indications that someone might be about to harm themselves? What are the things that a family member or loved one can recognize?
Right.
Can you tell us something about that, Jane?
Sure. So some of these, you could call them warning signs, and they're not always specific to suicide, but they are things that you should start being concerned about and feel comfortable enough to ask if somebody's thinking about harming themselves or taking their own life. And we want to make sure everybody understands that doesn't put an idea in somebody's head. It really can actually be reassuring to that person that you care enough to know what is really happening with them, what they're thinking about. And that gives you the opportunity to say, let's go get some help and I'll go with you. Let's take care of this. So some of those risk factors could be somebody speaking about they feel like they're a burden to the family. You could have an increase in different mental health problems, anxiety, depression, too much sleep, too little sleep. If somebody's talking about wanting to die or death or giving things away, you should take that seriously. And even if they're not imminently suicide, like they don't have an immediate plan, it's really important to get help. And it's actually easier to get help if somebody's not in an acute crisis. So it's actually a better thing if you're suspicious to get help sooner.
A related question from one of our viewers is self-harm an indication of potential suicide? And how does one differentiate between attention-seeking self-harm and serious self-harm? And I think self-harmful behaviors are risk factors for suicide. And I would say, even as a mental health professional, it can be very difficult to differentiate between attention-seeking self-harm and serious self-harm. And I think any self-harmful event should be treated as if it's a suicide attempt, because many of them are. And certainly it should be an indication to help if you notice it in yourself or in a friend, to get help from a mental health professional.
Right. I think we've got research showing that at times people are saying, oh, this is more for relief or it's a habit, but sometimes it is potentially, life-threatening. So people can go back and forth on that. And we do know it's a risk factor in the long run. So I would take it seriously, and it certainly isn't the best coping mechanism. It is a coping mechanism that people describe, but we would prefer seeing other coping mechanisms.
We have another question from a viewer. How do you feel about the collaborative care model to identify more patients in primary care at risk for suicide? So some of you may know the collaborative care model is something that we've been funding research for all sorts of purposes at the interface between primary care, medicine, and psychiatry. It involves what you might think, people working together to care for patients. And we found that it can be helpful in all sorts of settings. And we have an ongoing study to examine the role of collaborative care for suicide prevention. So as a scientist, it's not so much how I feel about it as it is what's the evidence. And I think the evidence is very promising for the collaborative care model to assist in suicide prevention efforts.
I think one thing that's important about it is it's this collaboration, this team. And we know we don't have enough psychiatrists in this country, and it's a great way to extend their expertise. So they could be on the team, they can help people decide when treatment should change. It's a team that also does making sure people are still connected to care. So we all also know those are important factors. And it's also one of the things that we know just in depression screening, that works very well with this model. It means that you can identify people, get them to the right treatment, they do better, they get better faster through this model.
So you said in depression screening, we know that depression and other mental illnesses do raise the risk for suicide. And there's another question, which is suicide genetic, that came in from a viewer? And another way to phrase that is, are there genetic risk factors for suicidal behavior?
Yes, absolutely. But like anything else that has a genetic risk factor, if you know about it, you're aware of it, you can work to manage the risk. So that can be helpful in a healthcare setting for sure. And that could be added to medical record information. So we're actually in the middle of looking at how do we put all those pieces together to understand somebody's risk and then do something about it to mitigate the risk.
Here's a great question that popped up. What resources do we have for teens who are having peer challenges at school and having suicidal thoughts? Are there tip sheets or something for parents to use, or for that matter, for schools to use to try?
It's a great question. And I think youth are much actually more open to talking about suicide. And I think sometimes the adults are catching up with them. And what I would recommend for people joining us today is to check out the Suicide Prevention Resource Center. It's a great place to look at resources for schools, universities, and healthcare, as we were already mentioning. There are toolkits there for parents, for teachers, and this is something that I think will continue to evolve because I think we'll be improving like health curricula at schools as kids understand more about this and as we can think about what's effective prevention. So kids don't even get to the point of thinking about suicide.
So that's the Suicide Prevention Research Center and
Resource
the website,
Center.
Resource
Yeah.
Center, thank you. And the website for that is
sprc.org.
sprc.org.
Yep. It's a great resource.
I want to add, actually, while we have that moment, I want to remind people what I said at the beginning of the Facebook Live event, that if you are having trouble and want to reach out for help, a great source for help is the Suicide Prevention Lifeline at 1-800-273-TALK. That's 1-800-273-8255 or suicidepreventionlifeline.org. I also want to mention another web resource now that we're talking about web resources, which is hosted on our own website, www.nimh.nih.gov. Within that, we have a suicide prevention page. The easiest way to get there is by going to our website, nimh.nih.org/suicide prevention. Or if you forget all that, Google NIMH suicide prevention. That works too.
Yep.
So let's take another question. How can professionals engage families in suicide prevention?
So families end up being sort of the therapists at home often if somebody's being treated in an outpatient setting. There's accreditation bodies for hospitals that have recommended that family members be informed, be a part of the team, the treatment team. So if the professionals that you're seeing have not engaged with you yet around this, ask them. It's really a best practice because everybody needs to know what they're going to do. There's also this tool, or I'd say even call it intervention, of safety planning. So you might want to develop ways of, if something's feeling like a crisis is coming on, what can I do? Who do I talk to? What coping skills do I have that I should remember to try to use? And you can have different levels of this. And that's a tool that's very useful for families and individuals to use.
Yeah, in my own practice, seeing patients who had suicidal thoughts, safety planning was a tool that I used a lot. It can be modestly effective, but a key component of safety planning is involving family members and friends. And I would typically bring them into the office and have frank conversations with them and the person suffering, and come up with plans together. And that's been shown to be effective ways. And we have additional research around that topic. For example, looking at caring communications, that is, approaches to increase communication around suicide as an effective therapeutic.
As a way of staying in touch and how are you doing? And some of those communications can be reminding you to use those resources.
Now, we talked about identifying those at risk, and as an effective way of identifying is what we call universal screening. That is, asking everyone who comes into a healthcare setting about their suicidal thoughts. And there's a great question pertaining to that. What is the best way to explain to parents that you are screening their young child for suicide and not having them get defensive or concerned? Oh, you're asking my child about
Right.
suicide.
Sure, it's terrifying to a parent to think that their child's thinking about this. So I would suggest looking at that ASQ toolkit, because there's a lot of information there to help both providers and help family members understand why this is the case. And what we found in a lot of screening, or even talking to, if you're administering the screening orally, talking to somebody, if they're not suicidal, they'll say, I'm not. If they are, they will tell you. And so it's really important to get that information out. It doesn't go away if you don't ask about it. It's there. So it's much better to understand what's there. And I think giving parents tools of, here's what we're going to do about this and how to make it a safer place is really important.
Yeah, no, I think it's really important to maintain open channels of communication, like in most areas of life, but particularly in healthcare provider, patient and or parent interactions. And the ASQ toolkit, which is again available through our site, nih.gov/suicide prevention. It provides not just the questionnaires, but some context to the questionnaires to be able to explain to your patients and to their families.
Right.
The next question, the latest CDC report found that about 54% of people who died by suicide did not have a mental health diagnosis. Therefore, it seems we need to expand beyond our current mental health centric approach. And what are my thoughts on that? So first, the CDC report did come out in the spring and have what to many of us was the surprising result that over half of those who die by suicide do not have a mental health diagnosis at the time of death. And there's two parts to that. One, I think the question is completely correct. We do need to expand our approach to suicide prevention beyond mental health care settings. And that's why we've emphasized things like emergency rooms and primary care settings as where you're seeing your general physician as places to identify those at risk. And that's the only way we're going to be able to reach that large chunk of people who are at risk of suicide, but who aren't seeing a mental health care provider. That said, we've long had research into the antecedents, that is the risk factors for suicide. We know that mental illnesses are strong risk factors. And we also know that if you look carefully into the lives of people who've died by suicide, that many more than 54% of them will have evidence of a serious mental illness, probably closer to 90%. Which means that most of those people who are succumbing to suicide, they are actually not getting the help they need for a mental illness that we can potentially treat. So that's all the more reason to reach out into these non-mental health settings to try to identify those at risk, is because we probably can help them in lots of different ways.
Right.
Another question, what are some healthy methods to discuss the topic of suicide with someone you fear is at risk, especially if you're afraid of triggering them or of not validating their feelings?
So it's a difficult topic to bring up, absolutely. So you want to start asking them just generally how they are doing, if you can find out more about what's happening in their lives. And you can ask, I'm really concerned about you. Have you thought about taking your life? Because here's what's worrying me about that. So it's all done in a caring and supportive way. The validating part comes, that's sort of like a clinical question, but validating is really trying to understand that person's feelings and understand where they're at, so you can meet them where they're at and try to help them get some professional care.
Yeah, I think that's an excellent point. As we mentioned earlier, the research shows very clearly asking people about suicide does not increase their risk. Nonetheless, even though I know that data, I know it's hard to bring that up right off the bat. And so it is important to talk to someone generally about how they're feeling before asking them as what might seem as a rude or brisk question as, are you thinking of hurting yourself? But the truth of the matter is that those who are not thinking about hurting themselves are not going to be too offended. And those who are thinking about killing themselves, they are the ones who will feel validated when you ask them. They'll say, I haven't wanted to talk about it, but yeah. And they will find that experience to be therapeutic in and of itself. So, and it's not just experience, we have data on that. we have research that shows that the act of asking is a helpful act.
That's right.
Another excellent question is, are there resources for veterans? And the questioner points out that they account for about 14% of suicides in the U.S. according to the Veterans Administration.